acknowledging the good work of the African CDC. And I don't say so because of my good friend John Nkengasong, but because I've been at the coalface and I've been able to personally witness the hard work and dedication that has really enabled us across the continent to respond appropriately to this pandemic. So what I want to do in the next 10 to 12 minutes is I'm going to tell you quickly about epidemic trends and about variants. And let me start off with what's the situation in the world? Well, we all got a surprise that in the middle of January, on the 11th of January, the epidemic started declining at a global level. And we saw for the first time ever in this entire epidemic, almost a year to the day, that the epidemic showed a consistent decline from the 11th of January to the 18th of February. And over those 5 weeks, the epidemic at a global level declined by just over half. So that's quite a steep decline and a consistent decline. Unfortunately, it's sort of not staying that way. It's now trying to decide whether it wants to stay flat or go up. And we'll keep a very beady eye on that. And I'll talk about this decline because it's really a very significant decline, because we've seen declines before, but those have been declines for a week. But a 5-week decline in this way, well, the first is to recognize that the pandemic is a mosaic of country epidemics. And you can see that in the way in which the countries are colored differently in the slide on the right-hand side. And you can see that our continent has been much less affected compared to North, South America, or Europe or Asia. But you can see that at the far end of Southeast Asia, that those colors match much of what we see in Africa. So we have seen a global decline over 5 weeks. Well, when you look at that decline, you want to understand what are the drivers of that decline. Well, the drivers of that decline are principally the declines we have seen in the US and in Europe. And the reason why we're seeing those declines, I'll come to in a minute, but essentially countries in North America and in Europe are now completing their winter second waves. If you look at, how are we in Africa contributing to the global pandemic? Well, I have to say, thankfully, a very small contribution. If you look very carefully, you'll see Africa right at the bottom, above March 1st, 2021. So we make a very small contribution to the global pandemic, and we have a minimal impact on the global pandemic numbers and the global pandemic trajectory. And let's look at, so why are we seeing this decline? Well, if we look at Africa, we've contributed in a little way to that decline because we've seen our own decline. And that decline that we are seeing is being influenced by South Africa largely. And you've already heard the numbers, so I won't go through it. Professor Nkengasong has outlined very clearly where we are in the global pandemic. So let's go on to the 4 key reasons why COVID-19 cases decline so that we understand what we are observing in the global trajectory. So the first is that if you take the population, there's a subgroup, a small subgroup of people who are those who are most at risk. So those are the individuals who move around a lot. Those are individuals who may not be following the rules. Those are individuals in high-risk occupations. So those individuals who are most at risk, they tend to get infected quickly when the epidemic is increasing. And once they've been infected, they are now immune. Now, we haven't reached herd immunity. Herd immunity requires a much higher level, but we are saturating with the natural immunity those who are most at risk. And so they don't get infected again, so we start seeing the numbers decline. The second is, of course, the impact of government interventions. That when you reduce the movement of people and gatherings, you decrease viral transmission. That's very clearly seen in South Africa. that when you look at when the government imposed restrictions in December, exactly 10 days later, our epidemic starts to decline, as you would expect in relation to the incubation period. And so you see the impact after the incubation period. Then we see an increase in protective behaviors during the waves. And when we have the cases going up, people become aware. And the whole issue of cases, people who are sick, people who are dying, becomes personal. The issues become personal. Somebody in your family, somebody you work with, somebody you know well. And so what happens is that we see an increase in protective behaviors. So it's a combination of people getting the most at risk, becoming infected and immune. It's government interventions. It's about protective behaviors and people taking protection personally. And then finally, it's the cyclic nature of the waves. And we see that very clearly in South Africa. If you look at our first wave, which is sort of more like an African Mount Kilimanjaro number of cases, and you can see the hospital admissions in the gray bars. If you compare that to our second wave, which was driven by the 501YB2 variant, you can see how the cases rose much faster and to a much higher level, akin more to like a Mount Everest than a Mount Kilimanjaro. And you can see that it wasn't just that the cases rose. The number of hospitalizations rose dramatically. It put a huge amount of pressure on the healthcare system in South Africa. And as a result, deaths go up. So we have now recovered from the second wave. The cases have declined for the reasons I've just outlined. And we are now in a situation of low transmission. And the government has eased restrictions and we are back to level 1, which is the lowest level of the restrictions that we have in place. So that's where we are in South Africa. I'm going to talk very briefly now about variants, because this picture that you see in our second wave is a picture of the impact of the 501YB2 variant. So what do we know? Well, globally, there are 3 variants of concern. The first is called the B117, and that was first described in the UK. It has lots of mutations, 23, but importantly has this one key mutation in the receptor binding domain, in that part of the virus that attaches to the human cell. Then you have the 501YB2 variant we described from South Africa in December. And there, the difference is that this variant has 3 mutations in that key part of the virus that attaches to the human cell. And then more recently, we've seen from Manaus in Brazil, the description of the P1 variant, which has more mutations and also has the same 3 key mutations in the receptor binding domain. So globally, we have these 3 variants of concern. The one I'm going to talk about is the one in the middle, the one that we know is present in South Africa and indeed is now occurring in other countries as well. So what do we know? Is it more transmissible? Is the virus spreading faster? Well, let's just look at one province in South Africa. If we look at the Western Cape and you look at its first wave in the light green line, you can get some idea of what the wave looked like. Compare that to the second wave, driven largely by the variant. You can see that the cases rose much faster, higher, and then from the peak, declined quite rapidly as well. So if you compare the two, it took the Western Cape 50% faster to reach 100,000 cases in the second wave, 54 days, compared to the first wave, 107 days. Now, there are many caveats to just drawing a simple comparison, but it gives you some idea of what the difference is. Our colleagues from the London School of Tropical Medicine and Hygiene have done a modeling analysis, and they find similarly that the variant is 50% faster in the way in which it's transmitted. So the variant spreads faster. So what do we know about whether it escapes immunity? So this is a bit of a challenge because we want to know, can you get reinfected? If you were infected in South Africa's first wave, with the previous variants of the virus, are you protected against this new variant? Well, just serendipitously, a vaccine trial that was being done in South Africa had 31% of its participants had past infection. And they measured the attack rate. And what they show is an attack rate of 3.9%. And it was the same whether you had past infection or you didn't have past infection. This is the first empiric evidence we have to show that past infection provides only minimal protection against this variant. And it's been confirmed by a range of laboratory studies. Penny Moore's group, based at the NICD in Johannesburg, and Alex Segal's group, based here, they're just one floor above me, their labs have shown that when you look at convalescent serum from South Africans who were infected in the first wave, you get, I'm just waiting for James to mute himself, you get high levels of immune escape with the 501YV2 variant. So it looks like that protection from the first wave is not provided against this new variant. But as you might have heard yesterday, our scientists have found that if you do get infected with this variant, that it stimulates very good immunity against itself. And so you would be well protected against getting this virus. And because of its cross immunity with many of the other variants, it also does well in preventing the previous variants. So what do we know about vaccines? How do these variants impact vaccines? Well, if we look at the B117 variant, there's minimal impact. You see slight declines in neutralization, and there are different assays that are used. I won't bore you with those details. But if we look at the 501YV2 variant, and I've here listed the 8 vaccines for which we have clinical data of efficacy, but not all of them we've got evidence yet of how their immune neutralization is impacted. But we can see that for the 501YV2, we have differing levels at which the vaccine immunity that's in the blood of vaccinees, we look at how well can they kill this 501YV2 variant. And what we find is that the activity of their antibodies is lower. Now, what does that mean? It's not very clear. It's still under deliberation as to what these mean. But let's look at clinical efficacy. Does the variant impact how effective it is? And we only at this point have evidence from 3 vaccines. And on 2 of them, we only have evidence for mild disease. We only have evidence on mild and severe disease for 1 vaccine, and that's the Johnson & Johnson vaccine. Well, if we look for mild disease, we see for AstraZeneca that the vaccine is 70% efficacious in the UK and Brazil, but only 22% effective in South Africa in the midst of the 501YV2 variant. Similarly, the Novavax vaccine was 89% effective in the UK, but 49% effective against the 501YV2 in South Africa. Johnson & Johnson showed a much smaller decline from 72% in the US to 57% in South Africa. We don't yet have clinical data for the other vaccines, and it's unlikely we're going to be getting clinical data because it's not practical. These studies take so long to do that we're unlikely to see clinical evidence from them. So we're going to have to look at correlates of protection to understand whether these vaccines are being impacted. So one of the key things that we need to be thinking about is how to prepare for the next variants and vaccines. And there are many things we can do, including improving our surveillance for these variants. And I'm very pleased that the African CDC has taken this on. Actually, they initiated the network of laboratories in Africa to do phylogenetic surveillance even before we knew about the variants. And we know that we've got teams like Happy in Nigeria and Tulio in South Africa, and they've all come together to help us ensure in Africa that we are monitoring what our variants look like. And that will give us important information so that we understand what we're dealing with in the virus. And then, of course, there's certain things we need to do. We need to be creating repositories. We need to be developing the capacity to produce vaccines reactively, and now almost every company is making a new vaccine. We already heard Moderna's is already made and sent for clinical testing. These new vaccines are based on the 501YV2 variant, because they will then produce more robust responses against this variant. We know that Pfizer is making them, Johnson & Johnson, AstraZeneca, they're all making this next version of their vaccine to deal with the variants. And of course, importantly, that the variants are created because of viral replication. Every time that a virus makes a copy of itself, it increases the chance of creating a variant. Variants are created when the virus makes a copy of itself. So when the virus is making lots of copies of itself, the chances of a variant are much higher. So we want to suppress that. We want to keep viral replication. We want to keep the number of copies of the virus being made low as possible. And the way to do that is to suppress viral replication. In other words, reduce the number of people getting infected. And so we need to do that with all the tools that we have, our prevention measures such as social distancing and masks and so on, and importantly, the rollout of vaccines, because the vaccines are part and parcel of how we can impact on the transmission of this virus. Remembering that even though we are seeing diminished neutralization capacity of these vaccines, and even though we're seeing lower levels of effectiveness against mild disease, it seems that these vaccines still remain quite effective in preventing severe disease and hospitalization. And that's why it's really important that we continue our efforts to roll out vaccines and to achieve global equity in vaccine distribution. Thank you very much.
Thank you very, very much, Prof, for that very comprehensive briefing. And I'm sure you've answered a lot of questions that people had in their minds. Now, let me invite Dr. Merawi Arago of the Africa CDC, who's going to give us a short briefing on the Ebola epidemic in the DRC and in Guinea. Dr. Merawi, good morning.
Good morning. Thank you, Madam Munit. Good morning, colleagues. So I will just give you a brief overview of epidemiology of the current ongoing Ebola outbreak in 2 countries. So as of today, March 4th, a total of 28 cases, Ebola cases have been reported in 2 member states in DR Congo and the Republic of Guinea. A total of 12 deaths have been reported, resulting in a case fatality ratio of 43%. This represents 64% increase in the number of cases reported this week compared to the last brief. In the DRC, since the last briefing, 1 new health zone, Butembo, has been reporting 3 new cases. Additionally, 2 new recoveries have been reported this week. Cumulatively, 11 confirmed with 4 deaths, with case fatality ratio of 36%, have been reported in 4 health zones in North Kivu province, and 2 healthcare workers are among the cases. This represents a 38% increase in total number of cases reported this week compared to the last week. 8 of the confirmed cases are known contacts, 4 of whom had been vaccinated. To break down by health zones, Bena Health Zone reported 5 cases and 4 deaths. Butembo Health Zone, 3 cases with no deaths. And Katwa Health Zone, 2 cases and no deaths. Museneni Health Zone, 1 case and no deaths. In the Republic of Guinea, since the last brief, 8 new confirmed cases, 3 new deaths, and no new recoveries have been reported in Zarakore, Guinea. Cumulatively, 17 cases with 13 confirmed and 4 probable, with 8 deaths, with case fatality ratio of 47% have been reported in 2 regions. 5 healthcare workers are among the cases. This represents 89% 9% increase in total number of cases reported this week compared to last week's brief. So by a breakdown by health zone, Conakry reported 1 case and no deaths, and this case has recovered. In Nizarikore, 16 cases reported and 8 deaths and 1 recovered. 9 cases are currently hospitalized in Nizarikore and receiving treatment. It should be noted that the case in Conakry traveled from Nizarikore and has since recovered. No active case currently reported in Conakry. Just to give you the update of overall response, and DR Congo, as of today, 634 contacts have been listed and 86% of whom are currently being monitored. 856 persons have been vaccinated, and the DRC Minister of Public Health is working with partners, including Africa CDC, in coordinating the overall response in North Kivu province. In Guinea, the general response is, as of today, 497 contacts have been registered, and all of whom are currently under follow-up. To date, 1,489 eligible individuals have been vaccinated, and the Minister of Health of experts into these for the affected countries and neighboring, high-risk neighboring countries, a team of experts. Thank you.
Thank you very, very much, Dr. John. Well, colleagues, we've had 3 very powerful presentations today. The first one from Dr. John, then Professor Salim Abdul Karim, and then lastly, Dr. Merawi Arago on the issues of COVID-19 and the Ebola outbreak. It's now time for our questions, so let's dive straight into that. Let's say good morning to Julia of Reuters, and this is Julia Paravicini. And Julia says, last week you said...
We're coming out of that latest feedback from the Africa CDC. To take you to the story now, German prosecutors are expected to announce charges against 3 former top officials at the global furniture and household goods company Steinhoff